Hi guys, welcome to the rheumatology section. I shall be now talking about Selena Gomez. Oops. I'm gonna be talking about systemic lupus erythematosus. Well, I would like to zoom into this image of Selena Gomez. She happens to be a Hollywood celebrity, a famous singer, and she suffered from active SLE. She lives in the most advanced nation in the world, that is United States of America. Still, she remained undiagnosed. She developed active SLE so bad that her kidneys failed. To save her life, they actually had to perform a kidney transplantation because once it's irreversible damage and an end-stage renal disease, you need to plan a kidney transplantation so that the person can have a healthy, fruitful life. Well, my objective was to sensitize you to the fact that a question that came in the previous years simply said that a young lady has been diagnosed with active SLE, and he said what is the leading cause of death. So I hope with this example you are not going to forget this fact that renal failure happens to be the number one cause of death in active SLE. Now listen to my next words even more carefully, because if this active word is not given in the questions, like he says, a young lady was diagnosed with SLE at 25 years of age and she died by 35, right in the first decade of life, then the cause of death is infections. Well, how is that possible? It's possible because we shall be using immunosuppressive drugs for management of this condition. We have highly potent drugs for management of flare-ups of these autoimmune disorders, and the downside of these immunosuppressive agents is that they can contribute to a possible infection which might be life-threatening also. So one, I want you to just be sensitized to this information from example of a celebrity. Before I discuss more regarding the butterfly rash in the inferior image you can see, I would also like to remind you regarding the skewed gender ratio for this particular disease. You would have read that the female to male ratio for this particular disease happens to be 9:1. I want to tell you that apart from SLE, even Takayasu's arteritis, which is an important cause of renal artery stenosis, especially in India, is also having a very skewed gender ratio. SLE is obviously the one, and the third example that you can remember for today is S. Jogren syndrome, which is discussed in the subsequent part of the app, which is also called as Sika syndrome and would be having dry eyes and dry mouth. These are three medical disorders where the gender ratio is extremely skewed. I also want you to remember that the severity of this particular disease is directly related to the number of X chromosomes. Let me just explain this fact to you the way it actually came in the exam. You see, suppose I give you two scenarios. One is a patient of Turner syndrome, second is Klinefelter syndrome. You are aware Turner syndrome is 45XO and Klinefelter will be 47XXY. Now, both patients are having SLE. Turner syndrome patient is also having SLE, Klinefelter is also having SLE, because the number of X chromosomes is more in a person of Klinefelter syndrome. So therefore, I can say that the severity of per se systemic lupus erythematosus is directly proportional to the number of X chromosomes. Actually, in the exam, he gave a couple of such syndromes. Examples were like Edward or Down syndrome or Turner syndrome and then Klinefelter syndrome. And all you had to do was pick up the number of X chromosomes and therefore come up with the right diagnosis. The characteristic feature that you will always notice in these patients, in fact, the most common presentation that is seen in these patients is not malar rash. The most common presentation of these patients is musculoskeletal complaints. It could be in the form of arthralgia and joint pain, which are the primary complaints. Most guys casually answer skin manifestations, that is malar rash as a predominant manifestation. That is, yes, it is present, but that is not the commonest one. The number one presentation of these patients is musculoskeletal pain along with fever, and then is hematological manifestation. You will see anemia of chronic disease developing in these patients, and subsequently it is the skin manifestations. I highlight that fact. If you check out the table in Harrison, it is musculoskeletal, that is 95%. Then is gonna be hematological manifestations. Then comes the dermatological manifestations. Now, malar rash is one of the features that you encounter in this condition, but in the exam, he tried to play a smart game. He wrote the word malar flush. The question was, all of the following are features seen in SLE, and you have to select the correct options and couple of people, because nowadays you have multiple correct answers in the exam. So lots of people who were casually reading the question, they did not read this word carefully. They thought malar rash and malar flush is same, which is not the case. Malar flush is a presentation that is seen with a valvular lesion, and I have discussed that in cardiology section. It's going to be mitral stenosis. I reiterate that fact, guys. Reading of questions is of paramount importance. 4 questions I've handled right away, which I would like to just repeat. If he says leading cause of death in active SLE, it's going to be renal failure. If active word is missing, infections. Point number 1. Second, skewed gender ratio, that is easy. You will not mess up in that. Number of X chromosomes, is directly related to the severity, and the term malar flush should definitely be picked up. And you definitely can see the classical butterfly rash which is present in this patient. This would be erythematous rash on the cheeks and will be involving the bridge of the nose as well. But most of the time in this disorder, nasolabial folds are spared. That's one of the highlights that you will always encounter, that though there might be photosensitivity, when she'll go out in the sunlight, the rash might actually increase. You see, in a hot Indian summer, if you go out in the sun, you might get a feeling as if your skin is burning. But if you will come out in the shade, if you come out from the sunlight into shade, then the burning sensation will go away. But in these patients, the redness of the skin, the burning sensation in the skin will still persist even when the patient has come out of the sunlight. So rash that is encountered in SLE is going to worsen on sunlight exposure and adopts that particular appearance. So it's called as a butterfly rash, or because it mainly involves the malar eminences, so that's why it's called as a malar rash also. It's a erythematous rash with raised margins. If you run your finger, you will be able to actually feel that the rash is slightly elevated as compared to the normal contour of the skin. And don't be under impression that seen only gonna be seen on the cheek and on the bridge of the nose. There's a distinct possibility that it can be even seen on the V of the neck or even on the hands of the person as well. So there are multiple sites that I'll write down subsequently where malar rash can be obtained. One of the highlights I want you to remember for this condition is that nasolabial fold sparing is present. You see why that is important is because if he gives a question and he's describing a man or a woman in which nasolabial folds are extremely red and they might even be yellow greasy flakes present that you can actually peel off, then that would be a presentation of seborrheic dermatitis. Seborrheic dermatitis per se tends to begin from the nasolabial folds, whereas in patients of SLE, it is a nasolabial fold sparing that has to be remembered. There are other dermatological manifestations of these patients also, like sometimes you might even encounter lesions that might look like psoriasis. So most of the time in multiple choice questions, he might write the word subacute cutaneous lupus erythematosus. You see, he might write acute SLE, he might write subacute cutaneous lupus erythematosus, and psoriasis-like lesions can also be present and even they will worsen on going out in the sunlight. Another manifestation very characteristically present in these patients could be a presence of discoid lupus erythematosus. In fact, these would be circular lesions. Like you can see, this is on the chin of this particular individual, a circular lesion that is present. The periphery of that is erythematous. And the center of it is having rather some kind of scarring also present. So dermal appendages will be lost. I want you to remember that when it comes to SLE, you will read in alopecia, it is always written non-scarring alopecia. The dermat guy would have emphasized it multiple times. SLE has non-scarring alopecia, but for the lesion that I'm describing at the moment, I'm not talking about scalp at the moment, I'm talking about a lesion on the chin, on the face of this person, that is going to be having a central scarring because dermal appendages are lost here. So there are two terms. One is non-scarring alopecia, that is not to be confused with atrophic scarring, that could be seen with respect to discoid lupus erythematosus. The word discoid basically tells you disc-like lesions. The periphery is going to be reddish. Initially, it might look like a fungal infection to you, you see, but in a fungal infection, the central part will always have a clearing. In this case, there's no clearing, rather there's a scarring component which is present. And obviously, along with this, multiple other manifestations can also be described, which would help you in identifying that this is a patient of SLE. In fact, there are multiple diagnostic criteria that I'll be explaining. In fact, in Harrison, what they have mentioned is the standard SLICC criteria, and there are newer ones which are called as EULAR or the ACR criteria. So I'll be discussing them both. Now, which one to answer in the exam, because they follow the textbook. So I would first like you to study with me what is given in Harrison. And once I'm done with what is given in Harrison, I'll definitely talk about the ACR criteria also, which are 2019 ones, which are said to be having a higher sensitivity and specificity. But if you want to understand those ACR 2019 criteria, the latest ones, in Harrison he has mentioned SLICC criteria only. We will first study those because to understand the latest ones, we need to have some baseline information about the disease. So I will next focus on which is an integral component, that is autoantibodies in this condition. There is a table in Harrison that I'll try to cover here before you and try to explain the implications of the various autoantibodies seen. The first and the foremost is anti-nuclear antibody. You see, this test per se would be having a 98% sensitivity in diagnosing the disease. I mean, you cannot diagnose SLE without an anti-nuclear antibody positive. But don't be under impression that anti-nuclear antibody is positive only in SLE, because anti-nuclear antibody can be present in multiple autoimmune disorders, and ANA could be positive even in scleroderma. So lots of time questions of scleroderma where I'll describe Raynaud's phenomenon, scleroderma crisis before you, the question will deliberately begin by saying anti-nuclear antibody positive. Even in S-Jogren syndrome, anti-nuclear antibody can be positive. So please do not be under an impression that anti-nuclear antibody is going to be positive only for a SLE case. It is going to be present in multiple rheumatological disorders. I've named 3 at the moment: SLE, scleroderma. They definitely are going to be positive, and so is the case of even S-Jogren syndrome. Lots of time, most people might even confuse this, or in a rush to answer, no, because time is the limiting factor nowadays in the exam. So they might actually miss the words, because one guy, he casually misread AMA as ANA. It was AMA, that is anti-mitochondrial antibody. Anti-mitochondrial antibody is what I have described in the liver section for primary biliary cirrhosis. So it has to be a quick reading in the exam. The strike rate is dependent on not only your knowledge base, but even to work out the information fast. Because if you are having, let me say, 2 minutes, 3 minutes to crack one question, you definitely will be able to get it right. But to get it under 1 minute, it takes a lot of dedication. It takes a lot of effort in reading the information fast. I have today explained to you that anti-nuclear antibody per se has 98% sensitivity. This is going to be the most sensitive test, as they traditionally ask you for diagnosis of systemic lupus erythematosus, but can be positive in other autoimmune conditions also. So other tests will also play a role. Lots of time when they ask what is the most specific test for diagnosis of this condition, people tend to give a wrong answer as double-stranded DNA. You see, the most specific test is anti-Smith antibody, double-stranded DNA antibody. This is for, then, you see, the question would arise, if this is not specific, then why are we doing it? Well, you are all aware that all autoimmune disorders will be having a waxing and a waning course. Sometimes the disease will become more severe, sometimes the severity will become lesser. Waxing and waning course, you can monitor with double-stranded DNA. The values tend to correlate with disease activity. So, like for example, if the disease will worsen in pregnancy, or if it improves, maybe postpartum, or it can be vice versa also, it was worsening postpartum and it was better during pregnancy, then per se, if he says which test will help in correlating disease activity of SLE, then it is double-stranded DNA values. The values can definitely increase and decrease, so you can monitor the progression of disease. For example, if I am treating the patient with steroids, then obviously the severity of disease will become lesser and the values of dsDNA will begin to fall. The third MCQ is anti-Smith antibody, which happens to be the most specific test for this condition. Well, no prizes for guessing that, because that's pretty straightforward and nobody will ask you these kind of questions nowadays. So now the term that comes up is that, can you tell me the antibody responsible for photosensitivity in SLE? Yes, guys. Which antibody in systemic lupus erythematosus is related to development of photosensitivity? Well, your answer is gonna be anti-Rho antibody. Anti-Rho antibody is also called as double SA, that is single-stranded antibody, SSA antibody. You need to remember this is going to be responsible for photosensitivity, which is going to be encountered in both acute and subacute varieties of lupus erythematosus. In acute, you could be having a malar rash. In the subacute variety, you could be having psoriasis kind of lesions. Even in discoid lupus erythematosus, all varieties. It could be acute, it could be subacute, it could be chronic, it could be written as malar rash, it could be written as psoriatiform lesions, it could be written as discoid lupus erythematosus. All lesions will worsen on exposure to sunlight. And another bad news here is that this antibody is immunoglobulin G class, so it can easily cross the placenta. So this lady with SLE got married, she conceived. Now once she has conceived, because the antibody can go transplacentally to the fetus, let us see how will it damage the heart of the fetus. So I'm going to talk about a condition where there would be damage to the AV node. Please appreciate that normally we study about infections going from mother to baby, but today I'm teaching you regarding a non-communicable disease going from mother to baby, that is SLE antibody is going over to the fetus and destroying the AV node. The end result for this would be that, the communication between the top and the lower part of the heart is definitely not there. SA node will now be able to control the atria, and bundle of his will be controlling the ventricle. So now it's like two pacemakers in the heart. On the top, SA node is controlling atria, and at the lower part, the bundle of is controlling the ventricles, and in between connection is not there. So coordination will not be there. This condition has been discussed in the cardiology section and is called as complete heart block. Well, the bad news is that if a lady with SLE will conceive, then there's a distinct possibility that her fetus and the baby will be developing neonatal lupus. This was itself a question. What is the presentation of neonatal lupus? Complete heart block. Which is the antibody involved? Yes, the same one that is involved in photosensitivity. The name is anti-Rho antibody. This kid will be having severe bradycardia at birth because bundle of his maximum firing rate is only about 15 to 30. As a result of it, lots of time this baby will also be having unresponsiveness. He will be having very sluggish Moro's reflex, and you might be under impression that he was having birth asphyxia, but no, it's not any birth asphyxia. The child is having a sluggish Moro or depressed reflexes because his heart rate is very less, BP is very less. To save the life of this child, you will have to put in a pacemaker. You see, in India already the facilities are less. To have a pacemaker, such a small one for such a small baby, is definitely a big deal. So most of the time in our country, either this child will either not survive, he'll never be diagnosed, we will think he's having birth asphyxia, and actually he's having a heart block here. So heart rate which is extremely low in a a cause of bradycardia in a baby right at birth, one of the causes to be thought of is complete heart block. This antibody by the name of anti-Rho antibody will also be encountered by you in Sitka syndrome. So when I'll be describing Sitka or S-Jogren syndrome subsequently, again, even in a lady of S-Jogren, because the same antibody is there and this antibody can cross the placenta. So therefore, a baby born to lady with Sitka syndrome can also be having complete heart block. Today, I've taught you two medical conditions where a baby born to a lady with a non-communicable disease, SLE and Sitka syndrome, because both diseases can be having anti-Rho antibody, can develop a manifestation of severe bradycardia or a complete heart block. The next on the agenda is an antibody by the name of anti-LA, lupus anticoagulant antibody, which is also called as SSB. Well, the good news is that with this one present, there is relatively a decreased risk of nephritis, and because that is relatively a good news, so he's unlikely to gonna ask about anti-LA antibody, because you see, normally as doctors we are interested in what things are gonna make the person feel or person relatively deteriorate. The next antibody in the sequence is called as anti-histone antibodies. That's again an easy one, less likely to be asked because this is studied even in pharmacology. It could be responsible for development of drug-induced lupus erythematosus. Don't mix up discoid lupus erythematosus with drug-induced lupus erythematosus, because terminologies, the DLE word might actually look the same. The good news about drug-induced lupus erythematosus is that patients may not develop lupus nephritis. Well, one of the biggest killers that I explained to you, active SLE, I explained, Selena Gomez, she almost died and she had to undergo a kidney transplantation. So lupus nephritis is not seen in drug-induced lupus. Lupus cerebritis is not seen in drug-induced lupus. Two important reasons why patients can die in systemic lupus erythematosus is not seen here. So relatively prognosis would be good. And anyway, if you discontinue the drugs, after 8 weeks, the disease might even regress also. What are the drugs notorious for it? Though there's a huge list, I'll just mention a mnemonic from the pharmacology domain, that is SHIP. That would be like sulfur drugs, then would be hydralazine, isoniazid, and procainamide. Out of the 4 that I have written here before you, though even sometimes statins are also given in the list, I would especially like you to remember procainamide. Procainamide is an antiarrhythmic agent which has been taught to you as a drug of choice in patients of Wolff-Parkinson-White syndrome as well as Lown-Ganong-Levine syndrome. These are conditions related to accessory pathways in the heart, and I've spoken about them in the cardiology section. So do remember the fact drugs responsible, especially procainamide, should be given its due respect and due importance. Then I would like to mention regarding 2 antibodies together. And before I write the name of them, I'll just give you a short clinical description and then I'll mention the name of the antibodies. I have this young lady. She has come to me because she tells me that her gynecologist has referred her to the medicine department or to the general physician because she's having recurrent abortions. Recurrent is defined as more than 3 consecutive abortions. You know that from OBGY. Or another scenario will be, she says that everything was going fine in my previous pregnancy till on a weekend she could not feel the baby moving. Now, because let me say she is not very well educated, she could not feel the kicking movements of the baby in the 3rd trimester, so she neglected that. And maybe it's been 2 days and the baby is not moving, so she got worried. She told her husband, and then they came to your clinic on a Monday. And because she said such an alarming fact that she cannot perceive the kicking movements of the baby in the third trimester, you did an ultrasound, and well, you had to break the bad news that the baby has expired. She says, Doctor, I was totally shattered when at 34 weeks of gestation, I was told in front of my husband that my baby has died. And when I asked the gynecologist why has it happened, my gynecologist was at a loss to explain to me that the entire pregnancy was uneventful till now, and now suddenly the baby died. And she says, maybe earlier I had recurrent abortions. So on listening to this kind of a history given in a question, I'll try to explain to her that we need to run a couple of tests in you so that we can at least know what is going on. One of the tests that I run in her initially is VDRL. And when it turns out to be positive, she's asking me, do you think I have syphilis, doctor? I mean, she says, I'm from a good background and no promiscuity, no abnormal, sleep arounds, etc. So she says, doc, I mean, how did syphilis come in? I'll tell her, ma'am, this test is actually false positive in you. This is false positive in you. Why? Because there could be an antibody present in your body which could be actually causing cross reaction with the VDRL kid and at the same time causing these recurrent abortions. So she's asking you, what is this antibody, doctor? So you will tell her that I suspect that there could be anti-cardiolipin antibody which could cross-react with a VDRL kit. I got a VDRL test done because I actually wanted to pick up this antibody which is responsible for recurrent abortions. In fact, in this condition, you will read about another antibody also, that is anti-beta 2 glycoprotein antibody. So this lady is actually asking you that, doctor, I'm not making any sense of these fancy names you're saying, no, cardiolipin, beta 2 glycoprotein. She's a non-medical. She says, what do I make out of it? I mean, why are they causing an abortion? I'll tell her, ma'am, these antibodies that I've just described to you, what they can do is they can trigger a uterine artery or a uterine venous thrombosis. And you can now understand, if you are having a arterial venous thrombosis, then the blood supply to the fetus is gone and therefore the fetus will die. She's an educated one, let me say, and she's asking you, okay, doctor, can you just explain to me how is this causing arteriovenous thrombosis? So to a non-medico, I can at least explain that clotting cycle will be having multiple steps, extrinsic step, intrinsic step. She may not make too much out of it, but at least I can explain to her the fact that the various steps of clotting are triggered when we have trauma. Like if I get a cut, like I am cutting onions for my breakfast, like I want to make a breakfast for myself and I accidentally cut my finger, it will bleed and then there will be clot formation. So there would be extrinsic step, there would be intrinsic step. In this lady, without any trauma, the autoantibodies are causing the clotting cycle to go in an automatic mode. The antibodies in this case will actually cause activation of the intrinsic system of clotting. I repeat my statement. The autoantibodies are causing the clotting system to go into automatic mode. They will stimulate the intrinsic system of clotting 24/7, and therefore clots would be formed in the arteriovenous circulation related to the uterine environment, and the end result is the baby will die. Well, the description that I gave before you here is called as anti-phospholipid antibody syndrome. We will talk about this subsequently also when I'll explain like what can be done for it. This is definitely asked in the exam. Anti-phospholipid antibody syndrome is in fact a hot favorite even in OBGY lecture. You would even see the obstetrician talking about it. But I wanted to highlight specially the names of two antibodies at this particular place. That is anti-cardiolipin and anti-beta 2 glycoprotein antibodies. These are the nasty ones which can contribute to a problem developing here in the form of recurrent abortions. I want you to remember that there is a very peculiar test also given in the textbook for antiphospholipid antibody syndrome. When you will write the name of this test, the patient will himself wonder, what are you writing? You are writing dilute Russell Viper venom time test. I mean, if somebody knows a little bit of English also, the person will definitely ask you, Dr. Viper and venom. So that's a very peculiar terminology. That's why this is asked DRVVT, dilute Russell Viper venom type test is used for evaluation of. Your answer would be APLA, antiphospholipid antibody syndrome, and this lady will be having tendency to develop recurrent abortions. What are we going to do for preventing such recurrent abortions? We'll definitely discuss it in the subsequent part of the discussion as well. But at the moment, especially the antibodies that I've highlighted, and especially anti-cardiolipin antibody, I can be incriminating that for a false positive VDRL. So the names of the antibodies are the crux of the discussion. In rheumatology, if you get the antibodies right, everything else will automatically fall into place. Other antibodies that you will read would be like anti-erythrocyte antibodies. So that is why RBCs will be destroyed. Though the common anemia that we see in these patients is anemia of chronic disease, but you can even have an autoimmune hemolytic anemia present in these patients. Then can be anti-platelet antibodies due to which thrombocytopenia will be present. So do not be surprised if you read about petechiae purpura developing in these patients. Petechiae will mainly be seen around the ankles, mainly because of gravity. Petechiae develop initially around the ankles and then they can progress up. Apart from these two antibodies, you can even have CNS manifestations. You would have read about lupus cerebritis. They could be cerebral edema. So what is the antibody which is crossing the blood-brain barrier, is causing a cerebral edema, is called as anti-neuronal antibody. Another antibody for CNS manifestations and should be remembered is called as anti-glutamate receptor antibody. The last antibody that I'm going to tell you on this topic will basically be regarding which antibody causes psychosis. Very peculiar, no? We expect neurological manifestations like cerebritis, but psychosis also, that the antibody causing psychosis is called as anti-ribosomal P antibody. This is usually given at the bottom of the table, whether you are reading it from Robbins or whether you're reading it from Harrison, then the table of the antibodies is given. That's the main crux of this entire discussion. The anti-ribosomal P antibody is going to cause psychotic manifestations. And now I'll tell you why people can actually mess up this MCQ. There is an alternative name of an antibody which might be having some partial rhyming. The name of the antibody now is RNP, that is anti-ribonucleoprotein antibody. You can see that when you read them for the first time, no, you'll read them casually, and he knows the fact that you can mess up between the two. Anti-RNP, ribonucleoprotein antibody, is the one that's going to be related to mixed connective tissue disorder. So I'll talk about what are the components of mixed connective tissue disorder subsequently. But at the moment, my request to you would be that before you proceed with the subsequent part of the lecture and listen to the clinical features, I would like you to go through this antibody discussion once again at maybe 2x speed. You see, clinical manifestations in rheumatoid are so many that unless and until you yourself seen a case, it is not possible to remember so many manifestations. It's a multi-system disorder. So understanding all the clinical manifestations always takes a backseat when it comes to a UG exam primarily or a PG entrance exam, because most of the time he'll give you a 10-liner question, but it can be cracked simply by the name of antibodies. So like I'll just give a random name, no? Like if I talk about anti-centromere antibody, if I talk about anti-topoisomerase antibody, the names I'll talk about in scleroderma. But if I know these names, even if I don't remember all the clinical features of scleroderma or major important features of scleroderma in the exam, because you have so much to read, then in rheumatoid, if you get the antibodies right, you are spot on. You would get 100% strike rate in the questions in case the antibody profile is flawless. I shall now be telling you a mnemonic that can be used to remember the manifestations of this disease. It would be called as MDSOAS brain. Though we will talk about the latest ACR criteria, the American College of Rheumatology criteria also, but at the moment we just need to understand how to work out these manifestations. Well, the first feature is very characteristic. I've already highlighted about it. That is a malar rash that would be sparing the nasolabial folds of the patient. You don't have to confuse this with seborrheic dermatitis where the nasolabial folds are involved, and neither do you need to confuse that with a cutaneous manifestation of sarcoidosis that is called as lupus pernio. Lupus vulgaris is skin tuberculosis where you read about apple jelly nodules, but lupus pernio is one of the commonest skin manifestations of sarcoidosis. This would be also involving the face. But in a sarcoidosis question, he will also talk about and will have to give in the clinical history massive hilar lymphadenopathy, because otherwise you need to do tests. From clinical domain, if you read a question that begins by describing a female with bilateral hilar lymphadenopathy contributing to breathlessness or stridor, then it's obviously not SLE, because in SLE I'll not be describing a hilar lymphadenopathy. The sites of the malar rash will not only be the face, that is mainly on the malar eminences, but it can even be the cheeks, or it could even be the earlobes of the patient. So I'm talking about sun exposed parts of the body. It could be the V of the neck, it could be the upper back of the patient, even extensor distribution, that is over the hands of the patient also. You could be seeing this particular reddish rash that is going to worsen on sunlight exposure. Lots of time he might use the word acute. Sometimes he might use the word subacute cutaneous lupus erythematosus. Rather, the term would be SCLE, that is subacute cutaneous SC stands for subacute cutaneous lupus erythematosus. I have already highlighted and shown to you in the initial part of the slide that this would be psoriasis-like lesions that would be having scaling present. And both of these lesions, it's not only malar rash, but even the psoriasis-like lesions could be having a photosensitivity component. Then the third skin manifestation that you encounter is called as discoid lupus erythematosus. For DLE, I want to highlight that the periphery of the lesion will be erythematous, it will be hyperpigmented, and the central part of this lesion will always be having atrophic scarring. By atrophic scarring, I mean dermal appendages will be lost. Now, I have shown an image on this particular slide per se, where I've also tried to highlight simultaneously the aspect of non-scarring alopecia. The alopecia component, the alphabet A, will come up subsequently in the discussion, but I just wanted to highlight this 2 times in this today's discussion. That is one, that when you talk about discoid lupus erythematosus, you will read the word atrophy or dermal appendages, but when it comes to the alopecia component, it is non-scarring. I have handled 2 alphabets here, M and D. Now I'll come to the S component, that is going to be serositis, where lung involvement and cardiac involvement will be present. I would like you to make a 2 by 2 table here so that you can remember these 2 manifestations right now, right here. In this 2 by 2 table, we'll talk about the number 1 manifestation with respect to the lung. That's going to be pleuritis. That will contribute to pleural effusion subsequently. And the cardiac manifestation will be pericarditis. That will subsequently contribute to pericardial effusion in the patient. On the other hand, when he talks about the least common manifestation with respect to lungs, then it would be referred as shrinking lung syndrome. Well, he can write either shrinking lung syndrome or he can rather mention a spirometric parameter to describe it also. Like one of the spirometric parameter to describe a patient having restrictive lung disease would be timed vital capacity is enhanced. So he can actually write which is correct about SLE. It is restrictive lung disease that can occur and therefore timed vital capacity would be enhanced in these patients. When it comes to the extreme right hand side, the least common cardiac manifestation, I'll have to explain this to you in detail. This would be called as Liebman-Sachs endocarditis. Though I have spoken about it in cardiology section, I would like to invest some more time into this terminology because this happens to be a neglected domain. You see, when you talk about Liebman-Sachs endocarditis, and please pay attention to the diagram that I make here, the sterile vegetations that develop in this condition, because SLE is a sterile condition, they are fibrin deposits and are predominantly present on the inferior surface of the heart valves. Though they can be present on the superior surface also, on the commissural ends also, but predominantly it is the inferior surface involvement that is seen. That importance of why inferior surface is emphasized to you is because inferior to the valves would be caudate tendineae. Caudate tendineae are the infrastructural support that's going to ensure that the valve functions flawlessly. In this case, the caudate tendineae will malfunction, because of which the valve integrity will be hampered, and therefore there can be leakage of blood across the cusps of the valve leaflets, and there would be a mitral regurgitation that could be developing in a patient. I want you guys to remember the fact that Liebman-Sachs endocarditis can contribute to a chronic mitral regurgitation, and this can definitely be symptomatic as well. Now, what would you do for this symptomatic mitral regurgitation of Liebman-Sachs endocarditis? Then don't answer steroids, because steroids will not treat the pulmonary edema component coming due to leakage of blood like this. See, the blood is leaking from LV to LA. It will go up to the left side of the heart. It will increase the pulmonary capillary wedge pressure. So the pulmonary edema component cannot be handled with steroids. For this, you will have to definitely go in for a valvuloplasty. So therefore, the concept of the question will be that in which condition in SLE will you not use steroids in a symptomatic mitral regurgitation patient? That is thanks to Liebman-Sachs endocarditis, the unfortunate scenario. That is where you will not be using steroids and you will have to go for a valve repair. I'll compile a list before you subsequently of where are the scenarios in SLE where you would not like to give steroids. But yes, this is one of the important ones. Liebman-Sachs endocarditis, because it causes a pulmonary edema component, because it's making the person symptomatic, we need to take action, and the action would be in the form of valvuloplasty. Another domain that can be asked here is with respect to chest pain due to pleuritis and pericarditis. You know that in pleuritis, the chest pain will worsen with inspiration, but in pericarditis per se, it would not have too much of a role with respect to the phases of inspiration or expiration. If in a doubt, you can definitely do a ECG, and pericarditis will show a classical ST elevation, concave upwards, as I've highlighted in the cardiology section. The complications of pleural effusion and Pericardial effusion can also develop, so he might actually talk about echocardiography showing a bag of water appearance. That would be in the later part of the disease in case treatment is not done, and a pericardial effusion will become relatively bigger. I will now be discussing the O component of the mnemonic. At the moment, I've handled three: Malar rash, discoid rash, and a serositis component. Now we're going to talk about alphabet O. That's going to describe oral aphthous ulcers. Well, aphthous ulcers can happen in any one of us due to stress, due to constipation, and they can occur idiopathic as well. And they respond to topical benzocaine jelly, the pain component, and they heal by themselves. You don't need to do anything for them. But in patients who are having SLE, there is a distinct possibility that these aphthous ulcers might occur on a recurrent basis. I want you to remember that it could be crops of aphthous ulcers, like there were 2 of them in the month of January, then they healed, and maybe 3 developed on the contralateral side or maybe on the same side in the next month. So it's on a continuous recurrence basis. A lots of time you will also notice that these aphthous ulcers might actually be painless. You see, if you and me have ever had a aphthous ulcer in our oral cavity once in 5 years, once in 10 years, it's gonna be mainly spicy food that will cause a problem. Sometimes if it is bigger, even drinking water might cause pain. But after a few days, the aphthous ulcer goes by itself and you can apply topical Zytiq lotion or benzocaine jelly, and well, the pain goes away. In this condition, I especially want you to remember that painless aphthous ulcer, why it's included as a diagnostic criteria, because it is painless. You see, aphthous ulcer is no big deal, no? It is that it is painless. That is why it has been included in the diagnostic criteria, and they will occur on a recurrent basis. Here, a word of caution. If a question begins by describing recurrent, R stands for recurrent, oral aphthous ulcers, and then describes that this lady is also having a recurrent vulval ulcers. You see, on reading a vulval ulcer, you might get the impression that you are reading about a STD. You might think in terms of herpes, but I want you to remember that the combination of these two and horribly painful. I mean, the patient will be extremely distressed that round the year she can't even eat food, and she's having genital issues also. So her sexual activity and sexual life will also be hampered. This is a presentation of Behçet's disease. There is a separate lecture inferiorly in the rheumatology section on Behçet's per se. I want you to remember this statement of mine. If you get a combo aphthous ulcer in the oral cavity plus genitalia, it is Behçet's. Otherwise, if it's only the oral cavity, the painless ones with other features that I've discussed, you need to think in terms of SLE as a primary diagnosis. I was trying to discuss the SOAS component of the mnemonic, where alphabet S would stand for serositis, O would be oral aphthous ulcers, and then alphabet A would stand for alopecia, which is of the non-scarring variety. I've already sensitized you to it almost twice, that for alopecia you have to answer the word non-scarring, whereas for discoid lupus erythematosus you have to answer regarding the atrophic scarring component present. Then alphabet S would be an important entry here, that is synovitis. So there are 2 S's here. One is serositis, second is synovitis. When it comes to synovitis, joint pain will definitely be a manifestation. This happens to be overall the most common presentation of the disease. Most patients of SLE will be young females, and they'll come to you with 2 complaints. One is going to be low-grade fever that might cause you to make a diagnosis as fever of unknown origin till it is proved that she's antinuclear antibody positive. And the second complaint would be related to joints. At least 2 or more than 2 joints can be involved in these patients, and well, which joints are involved? Then any joints can be involved. It can be small, it can be large, and it may be symmetrical, it might be asymmetrical as well. Most of the time in the textbook he has written the word intermittent polyarthritis. This basically means that there would be flare up of the disease. When the disease will worsen, that is when there would be pain. And any of the joints can be involved. It can be small joints of the hand as well as large joints like knee joint, etc. Whereas when it comes to rheumatoid arthritis, it particularly involves the small joint, and it's particularly a bilaterally symmetrical involvement. In SLE, it is not a hard and a fast rule. It may be bilaterally symmetrical, it may not be bilaterally symmetrical. Like today she's having pain only in her right hand, another day she could be having pain in her left hand or maybe in the left knee joint. So it is not a necessity that it will always be bilaterally symmetrical. In Harrison, the symmetrical word is not given to describe synovitis, though various apps and other classes might claim that. I want to highlight, you can yourself go and check in Harrison the synovitis component of the disease. Nowhere has he written the word symmetrical. He has written the word intermittent polyarthritis, which means that any joints can be involved. It could be small, it could be large. Like today it is the knee joint of the left side that is hurting. In next consultation it would be maybe elbow joint or small joints of the hand that would be involved in this case. The most common presentation of SLE overall is musculoskeletal complaints. It is the synovitis component. Here I also want to tell you that when I was a student, please don't note it down. When I was a student your age, we used to actually read this as arthritis. But now is not using the word arthritis because in some cases you may not even have erosions. A large number of cases, you see the standard presentation is obviously going to be tenderness. He's going to make it sound as if he's discussing a question of rheumatoid arthritis before you. He's going to describe a female. Rheumatoid arthritis is also female. He'll deliberately talk about here the small joint involvement. So tenderness, soft tissue swelling, akin to that you encounter in rheumatoid arthritis can still be described in a question. You would be able to identify primarily because rheumatoid arthritis is an example of a erosive arthritis. You always have deformities present, like they could be swan neck, they could be boutonniere's deformity, but in this case it is primarily a non-erosive arthritis. Well, please remember the fact that deformities can definitely occur even in SLE, but they are very rare. I repeat my statements once again. Majority of cases are those of non-erosive arthritis. Deformities can obviously occur because if a person will not take treatment, not come to you and the joint involvement is present, it can obviously contribute to erosive manifestations also. But majority of patients who are coming to you are symptomatic, you're giving treatment, initial presentation, main presentation of these patients is non-erosive arthritis. The last time I emphasized like this, non-erosive arthritis was in cardiology, remember, when I described rheumatic fever and rheumatic arthritis. That is where I was so emphasizing on the component non-erosive. At this moment, once again, I've emphasized even SLE would be having a non-erosive arthritis. Next, I would like you to be sensitized to this peculiar terminology by the name of lupus. This is going to be a combination of rheumatoid arthritis and the additional feature that you see is SLE. You will notice that rheumatoid arthritis can coexist with multiple autoimmune disorders. Like sometimes, in fact, I can just explain that to you. Lots of time you will notice that even with Sicca syndrome, you might be having rheumatoid arthritis coexistent. So apart from dry eyes and dry mouth, he might be describing small joint involvement to you. The technical term that you will use for this would be called as secondary Sicca syndrome, or you might use the word secondary Sjogren syndrome. The point is, whenever there's gonna be coexistent rheumatoid arthritis with any other autoimmune disorder, either you use the word secondary or like I have today here quoted Harrison, which has used the word lupus. This is mainly to highlight that there is a possibility that two patients or a single patient can be having coexistent two disorders, and as a result of it, the pain will definitely be severe because rheumatoid is definitely a erosive arthritis. That is why I was saying now that it is primarily a non-erosive one. Erosions can also occur because if the two diseases are coexisting, you definitely can have a problem. I'll next talk about the brain part of the mnemonic. Alphabet B would stand for CNS involvement that can occur in this person. If the question simply says what is the most common CNS involvement in a lady with SLE, your answer would be cognition defect. She'll become a little forgetful. Ability to do basic mathematics would be compromised. But unfortunately, if she develops lupus cerebritis, I hope you recall the antibody responsible for it. That was anti-neuronal antibody that can cross the blood-brain barrier and even can cause a cerebral edema component. So don't be surprised if you read about seizures, if you read about headache on a constant basis in these patients. Cerebral edema will explain why the headache and even seizures is written in literature of this topic, and you will also have a good response with dexamethasone or steroids because that will reduce the cerebral edema component. I've already explained to you that the antibody responsible for psychotic manifestations or psychiatric manifestations is also very frequently asked in the exam. I hope you can recall the name of the antibody. There were two things I said, anti-RNP, ribonucleoprotein, and then anti-ribosomal P antibody. Well, you would have thought about it correctly because I had already requested you to get the antibodies right in this topic. You can't remember all of these manifestations, no problem. But if you mess up on the antibody, the question is gone for sure. So if you just get what I am guiding you to, you would be bang on target. The psychiatric manifestation is in the form of psychosis. The antibody name is usually asked. So this is the details for the brain component. Now I come to the renal involvement in this condition. When I started this topic, I spoke about renal involvement and gave example of Selena Gomez in active SLE developing lupus nephritis. Well, lupus nephritis is quite frequently asked in the exam because it can contribute to mortality. Why would patients come to you? Because of two reasons. One would be the nephritis component contributing to hematuria, cola colored urine. That's a standard feature whenever RBCs are present in the urine, along with hypertension, and then features of end stage renal disease can also occur. That can contribute to uremia, it can contribute to electrolyte imbalances like hyperkalemia, metabolic acidosis. So there is a possibility that in the same question, he might use the opportunity just to extend the question by adding renal failure manifestations also. When I'll be doing a workup of this same lady, I'll be evaluating the renal involvement by doing a urine microscopic examination. If he says that hematuria is presence of more than how many RBCs, then I have highlighted in the kidney section that normally we have less than 3 RBCs present per high power field. Yes, we do have RBCs in the urine. I'm not saying that in a freshly passed urine you are having RBCs, but in a freshly passed urine sample, if you spin it in a centrifuge and examine the sediment in the urine of a normal person, you do have RBCs, it is less than 3. When I ask normally in a face-to-face class, most guys say there are no RBCs in the urine. Yes, you do have RBCs in the urine. It is less than 3 in a centrifuge sediment. If it is more than 3, it's a range given. 3 to 5, so I've written upper limit here. It's a range, right? So if it is more than 5, it definitely means that there is a hematuria. And because there's a glomerulus involvement, so most of the time there might be even written the word dysmorphic RBCs. Dysmorphic is always written whenever there is a glomerular damage present. Now, because this is autoimmune disorder, complement mediated damage will contribute to low C3 levels. The creatinine values will begin to rise, blood urea nitrogen values of this patient will begin to rise. So he's gonna utilize this opportunity to describe the renal component of the disease. When the examiner will incorporate the kidney biopsy findings of this lupus nephritis patient, he's trying to integrate the question of medicine with pathology. You see, you are aware of the fact that there are a total of 6 stages of lupus nephritis, out of which the most common stage happens to be stage 4. Well, stage 4 is called as diffuse lupus nephritis. I've written a short form here, DLN. Let me just complete it. Diffuse lupus nephritis is overall the commonest stage, though 6 would mean it is gonna be end stage renal disease. Diffuse lupus nephritis is when more than 50% of the glomeruli are damaged. Now, the reason why we are studying this is because per se diffuse lupus nephritis might be difficult to identify even for experienced pathologists, so they will have to use immunofluorescent studies. And when you will do immunofluorescent studies, you will be able to notice, and I'll just zoom in the image, you will be able to notice that it is written in the report that 3 classes of antibodies are deposited here: immunoglobulin G, immunoglobulin A, immunoglobulin M, even complement system like C3, C1 would be deposited. So because of so many antibodies, I'll just zoom in, and that was the image-based question that has come in former AIMS examination, where the student of mine showed that he could see multiple immunofluorescent study related to the kidney, and he could say that in the right upper quadrant of everyone, he could see antibody names and complement system written. The name that we use to describe this particular one is called as full house effect, and full house effect is something that we read in a game of cards. You see, we doctors are so busy that we don't get time to play cards. But if ever in childhood you played cards, then you can remember all these symbols which are present on the card. So just like I have shown here a full house, right? Similarly, the full house card effect is what they have described or asked in the exam as well. So it's mainly for the pathology integration here. The word full house effect, diffuse lupus nephritis, 50% glomerular involvement, that he'll describe all these clinical manifestations. And this is a big time killer. I mean, if SLE manifestations not treated properly, then this could be the main reason why the patient can die. Coming to the remaining manifestations of the disease, I've described brain manifestations, that is CNS, renal manifestations. Now I'll describe the A component, which is anemia. Well, if they simply ask what is the type of anemia that is seen in patients of SLE, then your answer would be anemia of chronic disease, and anemia of chronic disease happens to be normocytic normochromic anemia. But over and above this, there's a second reason for anemia developing in these patients. The reason for this could be, there could be antibodies, there's so many of them, which could be against erythropoietin. And then we have also documented antibodies which are present against erythropoietin receptor. I said 2 things. One is antibody against EPO, so that will cause enhanced clearance of erythropoietin from the body, so it will not be able to have its normal duration of action. And then would be antibody which will contribute to impaired response of erythropoietin. That's mainly because it is acting against the receptor on which erythropoietin will be acting. Over and above this, I also want to tell you that there could be autoantibodies in this condition which could destroy the red blood cells. There is a possibility that he can even give you a peripheral smear of this person. You would be able to see the pink RBCs with a central pallor as is the norm. But over and above this, you will also be able to see some RBCs that may not be having a central pallor. What I've just made before you is a red blood cell which is smaller in size and at the same time is lacking central pallor. This red blood cell is called as spherocyte. This is itself a question because if you encounter spherocytes in blood of an adult person, you don't have to think in terms of hereditary spherocytosis. You have to think in terms of autoimmune hemolytic anemia. In fact, I will have to jot it down before you. You see, suppose I'm describing a 2-year-old girl. She's having progressive anemia, so the parents are worried. When I examined the child, the girl is also having splenomegaly, and splenomegaly is always indicative of a hemolytic anemia. So I told the parents, please get a peripheral smear done, and peripheral smear revealed presence of spherocytes. So if I put all this question information together, child progressive anemia, spherocytes present, then we will obviously have to think in terms of possibility of hereditary spherocytosis. But if I change the question and describe a 25-year-old female, she's having a progressive anemia because hematological manifestations are the second most presentation of the disease. The first one was musculoskeletal, second was hematological, and the third one was the malar rash or dermatological ones. So if you are having a lady with anemia and the peripheral smear is showing presence of spherocytes, then I'm not saying that she's having SLE. Please appreciate, I'm not teaching you that she's having SLE. All I'm saying is if there's going to be spherocytes present, I'm going to think in terms of possibility of autoimmune hemolytic anemia. If they ask you simply, what is the type of anemia found in patients of SLE? Answer is anemia of chronic disease. There are multiple reasons why these patients are anemic. Anemia of chronic disease is the number one. Then could be antibodies against erythropoietin, antibodies against the receptor on which it is supposed to act, and lastly autoimmune hemolytic anemia. This AIHA component is quite frequently asked in the exam because this is usually given towards the end. It's easy to identify anybody or for anyone to identify that anemia of chronic disease can be associated with SLE, but then the allied aspects that I've said are definitely also gonna have their due importance. And for management of autoimmune hemolytic anemia, we will be giving steroids. Will not give packed RBCs because the antibodies are waiting to destroy the RBCs. You give a packed RBC, the antibody will be destroyed. Person might even have worsening or might even develop jaundice. At this juncture, I would like to remind you that I have described steroids are the mainstay of treatment for systemic lupus erythematosus, but they are not recommended, especially in a patient who's having symptomatic mitral regurgitation. Now, because he will write symptomatic mitral regurgitation and you obviously can simply use English to say that person is having symptoms, pulmonary edema. I will not give steroids. I'll go for valvuloplasty. I will give diuretics. So he will write the words like Libman-Sachs endocarditis. I want you to remember, it's not a guarantee that every patient of Libman-Sachs endocarditis will be symptomatic, but he is assuming that if the disease is progressive, there is a symptomatic patient, then you will not give steroids in the patient. Similarly, if a patient is having photosensitivity, then the rash component and the photosensitivity component per se, they go together, but photosensitivity does not respond to steroids. Remember, in the earlier part of the discussion today, I taught you that there are certain antibodies which contribute to photosensitivity, one of them being anti-Ro antibody. If he asks in the exam, and this is a question for you from pharmacological domain, can you tell me what drug is used for treatment of photosensitivity? She has tried everything, sunscreen, lotions, and she's tried avoid going out in the sunlight, purchase those big Ray-Ban sunglasses to protect the malar eminences. What drug would you use to treat photosensitivity component? Then your answer would be hydroxychloroquine. The same drug will also be used if this lady plans to conceive and have a baby. You see, even in pregnancy in SLE, we do not give steroids. I'll tell you the reason for that subsequently. But remember, chloroquine or hydroxychloroquine, specifically the one that was famous for COVID-19 initially, Trump was asking India for hydroxychloroquine supplies, and Prime Minister Modi, he asked all the factories in Baddi in Himachal Pradesh to, suddenly start getting this API of hydroxychloroquine from China and manufacture the drug and give it to America. The same drug is useful for photosensitivity in these patients. I have highlighted at the moment that if a person of SLE is on steroids, you are not supposed to give steroids for the following scenarios. You are supposed to give it in most of them, but definitely the ones that I'm jotting down, it does not make any sense. Like if I say active SLE, if I say lupus nephritis, yes, I will give it. But if somebody will go into end-stage renal disease, if somebody will develop uremia, then the treatment for uremia is hemodialysis. And to prevent recurrence of this uremia manifestation, I need to plan a transplantation. You cannot treat uremia by giving steroids. Similarly, there is a possibility that these patients might start developing psychotic features, and steroids themselves cause psychosis. I've written the data in decreasing order of importance. You can see that I put 2 stars in front of Libman-Sachs endocarditis. That would be the primary answer. But these are situations in SLE where you will answer that I will not use steroids. I appreciate the fact that you might ask me that, sir, Libman-Sachs endocarditis can either be asymptomatic as well as symptomatic. But yeah, because he's writing the terminology, he's applying that or implying the fact that person is having active disease, so there can be manifestations occurring. I have described this mnemonic to you by the name of brain, where I've highlighted the brain, the renal, the autoimmune, and the anemia component. Now I am going to talk about immunological manifestations. I would stand for immunological. Immunological would involve all the antibodies that have been discussed already, because had I discussed all those immunological criteria at the moment, you would have forgotten the clinical ones. So I decided to discuss all the antibodies initially. I would just like to remind you that the most specific antibody for this condition is anti-Smith antibody. Double-stranded DNA will help you in charting the course of the disease and the progression. And because this is type 3 hypersensitivity, there is a complement-mediated damage. So therefore, C3 and C4 levels will definitely be lesser. That leaves us with alphabet N to handle. This alphabet N belongs to the most important antibody for diagnosis of this condition, that is anti-nuclear antibody. So it gives me an opportunity now to actually first explain to you what are the important features of this disease. We'll see the Harrison table also, as you would have seen intermittently. I'm trying to show you subsequently, but let us first practice by ourselves what are the important features which are to be remembered for this condition, and then we will see how many of these will be required for diagnosis. The first feature that I highlighted was malar rash. He might write the word acute SLE rash. There could be psoriatiform lesions. There could be even discoid lupus erythematosus. All the 3 lesions that I've highlighted, acute, the subacute variety, the psoriatic form, and then discoid lupus erythematosus, all can be having photosensitivity. Person, when he goes in sunlight, that's when the redness and the inflammation part of the lesion will definitely worsen. Alphabet D in MD stood for discoid lupus erythematosus. Don't mix it with the drug-induced lupus erythematosus. It might look overbearing for you at this movement to recall all this, but please try to remember with me, because this is the time best one to actually remember it. Because if you think you're going to try and do it later, sir, you won't come back to this lecture. You see, most of the activities, academic ones, are low dopamine release ones. We love to do high dopamine release activities in our brain. Like watching a video on YouTube is what causes release of dopamine, so it's addictive. You just keep on scrolling. But this academic activity is low dopamine, so people don't come back to the lecture. So I want you to remember here only the serositis component will be having both pleuritis and pericarditis. I spoke about shrinking lung syndrome and even Libman-Sachs endocarditis there. Then can be oral aphthous ulcers. Oral aphthous ulcers are mainly painful, but in SLE they can be painless as well. That is why they have been made as an important diagnostic criteria. Then would be non-scarring alopecia. Then would be synovitis. Now arthritis has been removed from the diagnostic feature. It is synovitis which is to be considered, at least 2 joints getting involved. It is intermittent polyarthritis, both small and large, large. I mean, any combination can be there. Small plus large, large or small joints can be involved. Then you can be having brain involvement. That would be CNS1 in the form of cognition issues or even psychotic manifestations. Then would be nephritis, which can progress to even end-stage renal disease. Then would be the anemia component, which could be anemia of chronic disease as well as the autoimmune hemolytic component. The bad news is the autoantibodies will damage self-WBCs. So even you could have a leukopenia. The antibodies, the antiplatelet ones, will cause a thrombocytopenia. So don't be surprised to read these 2 manifestations of petechiae and recurrent infections in these patients as well due to decreased TLC. I will now move to the right side of the slide where I'll explain to you certain immunological features. You see, for diagnosis, what we are doing is we are incorporating some clinical features on the left hand side and immunological features on the right hand side. Now, immunological features that can be written can be something as simple as direct Coombs test. You are all aware that whenever we have autoimmune hemolytic anemia, Coombs test is positive. Obviously, the standard information will be given because you can't make a diagnosis of this disease without anti-nuclear antibody. But because ANA and anti-Smith antibody make it relatively easy for anybody to crack it, so he'll usually talk about direct Coombs test. Then he will talk about aspect related to recurrent abortions. The antibody name is lupus anticoagulant antibody, LA antibody. This is itself a misnomer, no, because anticoagulant would basically mean that there would be a clotting tendency. The more specific antibody that helps you know why a person is having recurrent abortions is called as cardiolipin antibody. It is written in short form as ACL. Then was beta 2 glycoprotein antibody. The anti-cardiolipin antibody was the one which was responsible for a false positive VDRL also. He can be using any of these terms for the bad obstetric history component: lupus anticoagulant, ELISA anticardiolipin antibody, anti-beta-2 glycoprotein antibody, low C3, low C4. Guys, I want you to remember that for diagnosis of systemic lupus erythematosus, out of all the features that are described to you with MD, SOAS, brain, and these immunological features mnemonic, I want you to remember that at least total 4 features should be positive. Out of these 4 positive features, at least one clinical, at least one feature from the left side of this discussion, and at least one feature from the right hand side of this discussion should be present. At least one clinical feature and one immunological feature should definitely be present. For example, there could be 3 features from the clinical side. You have a lady, she comes to you, she says, I have joint pains all over, multiple joints at different times. She's also turning anemic and she's also having a malar rash plus ANA is positive. Or it could be only one clinical feature and there could be 3 antibody tests which are turning out to be positive or immunological features positive. So it could be either, total 4 points have to be there. Either it could be only 3 clinical and 1 laboratory feature, or vice versa. It could be 1 clinical and 3 laboratory features present, but total 4 have to be demonstrated. And the same thing was from the Harrison snapshot that I'm trying to show before you. So I'll just bring that to your notice. The skin manifestations can be written as acute or subacute cutaneous lupus erythematosus. That could be psoriform lesions. And when you talk about chronic cutaneous, that is where he will talk about DLE, discoid lupus erythematosus, which is mainly on the face, on the chin of the person. Then could be oral ulcers, it could be alopecia, synovitis. I've shown, I'm showing this Harrison snapshot because lots of people, they send me queries, sir, I have read arthritis. That is the older classification. The newer one talks about, and I'm going to talk about the brand new one also, but synovitis is the term, not the arthritis component. Then can be renal involvement because proteins are going to be elevated plus RBC cause. So there's a glomerulonephritis component, and biopsy itself is one of the best ways to diagnose. I mean, if a person is biopsy positive for DLN, diffuse lupus nephritis, it is SLE. So one feature, I mean, why he has put an asterisk here in front of biopsy word in Harrison is mainly to highlight that if somebody, like in Selena Gomez's case, if it is biopsy proven diffuse lupus nephritis, it is SLE. Then can be neurological features, anemia coming up, leukopenias, thrombocytopenias, and the antibody test, which can help you in confirming the diagnosis of SLE. Total 4 features need to be positive. It could be clinical ones, 3, and 1 immunological, or vice versa, as I've explained. Now, the reason I have done this activity once again is mainly to sensitize you to what is the latest ACR criteria, which were published in 2019. They are not given in Harrison. I would like to specify the fact that in this clinical criteria, out of everything that I've said, the only thing extra that is present is only fever. Now you might be just smiling, sir, fever? I mean, you think that fever is such an important thing? I just want to highlight that these criteria are almost the same. The difference is that when it comes to the ACR criteria, he has given weightage to each of the features. Which of the following features would be having the highest weightage in this ACR criteria? Then it is renal biopsy. As I was saying, you can see 10 points given to renal biopsy finding. On the other hand, when you read about features like pleural effusion, pericarditis, the points will vary. You are not expected to remember the point system. Nobody can remember that. No, it's software that is available nowadays. When you have a patient a suspected SLE, all you will do is you will use this clinical criteria. Like for example, I'll just give an example here. Suppose hematological manifestations are there. There is hemolysis also. There is thrombocytopenia also. So you will not consider both. He says in the hematological, like there are 3 points: leukopenia, thrombocytopenia, autoimmune hemolytic anemia. All three are present in the patient. So the score will not be 4 plus 4 plus 3. He will say that you have to select the highest rating from hematological, highest rating from neuropsychiatric, highest rating from mucocutaneous. If the total score of the patient turns out to be more than 10, with anti-nuclear antibody positive. I repeat that once again. If you have a patient who's anti-nuclear antibody positive with these features like fever, hematological ones, musculoskeletal ones, each category you have to take the highest particular value of a particular feature. Like hemolysis is also present, thrombocytopenia is also present. Hemolysis rating is 4 and thrombocytopenia rating is also 4. Leukopenia is 3. You don't need to add all the 3 up. Just select one out of these. And the total score should be more than 10. So it is unlikely that in the exam he's gonna ask you the individual scores. I mean, that's gonna be very mean of any examiner to ask you, because nobody can remember it, sir. I mean, it does not make any sense. But for you to understand all these, because had I started with this particular table, and that is why I think it's not given in Harrison, is because if I just started like this: hematological, 3 points for leukopenia, 3 points for thrombocytopenia, 5 points for seizure, it would not have made any sense to you. The sense would be, first I teach you antibodies, which are the troublemakers, and then what are those antibodies going to cause? They're going to cause lupus cerebritis. That will cause a cerebral edema component. That will explain the seizures manifestation of a patient. Because it is autoimmune, the complement system would be consumed. That is why the low C3 and the low C4 values are given. So I have tried to explain the disease in a retrospective fashion. I mean, instead of only talking about the criteria or the clinical ones, I have first highlighted on the most important part of the discussion, getting the antibodies right. I would lastly like to mention that if he says what is the drug of choice of SLE in pregnancy, then do not answer steroids. Well, why should you not answer steroids? When I ask my students, a lot of them say, sir, teratogenicity. No, it is not that steroids are teratogenic. That is why we are not giving them. We do give steroids. Like if a lady is having asthma, no, we do give oral steroids if required. We also give inhaled steroids in pregnancy. So it is not that steroids are teratogenic. The reason why we are not giving steroids, I'm just putting a cross in front of steroids to say we don't give steroids in pregnancy, is because they are deactivated by the placental enzyme. So if a lady is having a flare up of her symptoms in pregnancy, because lots of time autoimmune disorders can worsen in pregnancy. So if there is going to be a flare up of the disease in pregnancy, then even if you give steroid, they will not be able to act. Why? Because the placental enzymes will deactivate them. So he says you need to use hydroxychloroquine. So I have told you 2 uses of hydroxychloroquine at the moment. That is going to be photosensitivity in SLE and SLE with pregnancy. As far as death in SLE is concerned, that is again something which is a subject of debate, because I spoke about infection as well, and I spoke also about the fact that there can be active lupus nephritis occurring in a person. So this is what CMDT is saying. He says in the early years after diagnosis, if a person is dying, it is mainly because you had given treatment. You see, you are in a catch-22 situation. You don't treat, patient dies. You treat, patient dies. So you have to select the middle path. The highly potent steroids which are used in flare-ups of this disease can contribute to infection. If he specifies the word active lupus or active SLE, then it is definitely a renal failure. The next statement will look little surprising, but you will get used to it. After 45 years of age, the leading cause of death is cardiovascular mortality. I want to highlight this once again. If he specifies SLE patient is not a young female, she suffered from the disease for 20 years. Now she's 45, 50. You see, normally in India, atherosclerosis will occur around about 60 years of age. In America, maybe 70. But this lady at 45, 50 is having atherosclerotic changes. So accelerated atherosclerosis is the cause of death in later part of life. There is also problems from the fetus perspective. There are 2 problems from the fetus perspective. One, the fetus might actually die. Abortion, intrauterine death possibility is there. Or even if he is born, he might be born with a complete heart block. The antibodies for the two are totally different, and I usually find people, tending to forget that the antibody responsible for abortion versus complete heart block are totally different. Well, I hope you can recall the two, no? And I know it causes stress on the brain. The antibody that is going to contribute to abortion is anti-beta 2 glycoprotein antibody. After that, you will answer anti-cardiolipin antibody if not given in choices. Otherwise, both of these, they cause the clotting cycle to go into automatic mode. Intrinsic system of clotting is set into automatic mode. So thrombosis of the uterine artery and vein will occur. And for complete heart block, it would be anti-Rho antibody, which is also called as anti-SSA antibody. So these two names, if you remember, then you are done with these questions, which can be asked in pediatrics as well. Lastly, for this topic, I would like to show you some references. One, I've highlighted that anti-nuclear antibody can be present not only in a case of SLE, but can also be present in scleroderma. Even the localized version of it, that is CREST syndrome, will be having 95% positivity. I have just highlighted or marked those which are having at least 95% positivity. Otherwise, ANA can be positive even in rheumatoid arthritis, but the positivity is lower, as you can see, 30 to 60%. Then I'm showing a reference of CMDT, current medical diagnosis and treatment. I'm zooming into the main section where I have shown decade-wise mortality. Because I know this is a controversial issue, so I started the lecture with it. I'm now showing a reference from CMDT, which mentions that mortality has a bimodal presentation. In earlier years after diagnosis, it would be infection, but later on, if it is active SLE, you can see it is the kidney part, and still in the later years, that is 45 years or later, it is accelerated atherosclerosis. Lastly, I would like you to revise the antiphospholipid antibody syndrome diagnostic criteria. You will read words like primary and secondary antiphospholipid antibody syndrome. I want you to remember that if it is present without SLE, we call it primary. If it is coexistent with SLE, we call it secondary. There would be clinical criteria, there would be lab criteria. The technical term written is Sydney revision of Sapporo criteria, where at least two things have to be demonstrated. One, event like vascular thrombosis. What I mean by vascular thrombosis is this young lady at 25 years of age could have a MI. She could even have stroke, and therefore low dose aspirin will be prescribed on lifelong basis for management of these patients. Otherwise, these unfortunate organ thrombotic events can occur. We also need to demonstrate the pregnancy morbidity component, where I've highlighted regarding intrauterine death or aspects of recurrent abortions occurring in the patient or placental insufficiency. And along with these two clinical ones, we also need to have a laboratory feature coming up. The laboratory features can be anti-cardiolipin, anti-beta 2 glycoprotein, lupus anticoagulant. Any of these three can be present, but at least they should be repeated 2 times, at least 12 weeks apart. Do remember that laboratory term. I highlighted that any of these 3 tests can be positive, but they should be positive at least 12 weeks apart. I also want to tell you that if there is more than 3 body systems involved in this patient, like for example, brain was involved, heart was involved, then even kidneys were having a thrombotic event, then we call it catastrophic. CAPS stands for catastrophic. As the name itself will suggest, no, catastrophic means a very extreme level event. Catastrophic is when more than 3 body organs or 3 body systems are involved in a person serially. Obviously, they not get involved simultaneously, but one after the other. Like this year, she had MI, then she had a stroke. So on a serial basis, if 3 body system involvement is demonstrated, we call it a catastrophic antiphospholipid antibody syndrome. This topic is covered in OBGY as well, but I thought I'll just try to do justice. And false positive VDRL can be a possibility in this condition. Though it's not written in the diagnostic criteria, it may be written in the MCQ. Why? Because when I was describing the clinical features of SLE, I showed you Harrison table also. No? Then I was talking about aspects of false positive VDRL. So you can see that it's written in the diagnostic criteria. Antiphospholipid antibody, if it is positive by any one of them, it could be lupus anticoagulant, any of those known, LA, lupus anticoagulant, anti-cardiolipin antibody, anti-beta 2 glycoprotein antibody, any of these terms written, they are included in the diagnostic criteria of SLE, but false positive VDRL per se as a word is not included in the diagnostic criteria or with respect to antiphospholipid antibody syndrome. So these are the details that I want you to remember for this topic. Keep hammering, keep learning, keep on upgrading your knowledge, and I'll definitely see you sending me messages regarding your success stories. Thank you so much for hearing me out.